Okay, so can you hear me now? Is it fine?
Yes, perfect. How are you? Good morning.
Good morning. Fine. Thank you, Piano, for inviting me. I'm speaking from Rome. It's an honor for me to be contacted like this.
Okay, perfect. It's a very great pleasure to have it with us. You are going to be the first speaker here in the meeting, so you can start whenever you want.
Okay, so if you think so, we can probably put up the slides and start with my presentation.
Yes, perfect.
When you asked me to give you my talk, well, I thought that you are quite familiar with all possible types of keratoplasty, developed over the years in Forlì, and you probably have seen. Can you move the next slide, please? Okay, we all know very well there are advantages in the sizes of graphs. Small graphs, but their optical properties are not very good because they are often very distorted, and even if they remain clear, the opposite is true for large graphs. These graphs, have usually a less error, but the possibility of rejection is much higher because they get close to the limbus, and for many reasons, they are more prone to be rejected. Next slide. And this comes into play with what you will see next, is that actually the posterior surface of the cornea is not a stable situation. Basically, the endothelial cells on this posterior corneal surface migrate from the areas where they are more dense to the area where they are less dense. This has been shown by many authors. Next slide. And so, for example, if we transplant a keratoconus patient, this is a schematic situation, even if the center, the yellow graft, has few cells, there are a lot of recipient endothelial cells in the crown or the graft that can migrate across the wound into the graft to repopulate the posterior corneal surface and make it possible to make this graft survive over the years, although it started with less cells. Next. Calculate a graft of 6 millimeters left compared to the whole corneal surface we assume with a radius of 6 millimeters. Next slide. You see that actually performing a 6 millimeter graft full thickness corresponds to transplanting only 25%, more or less, of the recipient, leaving in place 75%. And this is an amount that is enough even to fully repopulate the central 6 millimeter. So even if it decompensates completely, can be repeated by the and survive. And this is probably one of the reasons why these small grafts survive over the years, over 30, 40 years, better than large. Next. And so if we have a patient like this that has a bad stroma, a 100% scarred stroma, but good endothelium, we want to use that concept to minimize the amount of endothelium we transplant. Next slide. And this is true for all these situations where we have a full thickness stromal disease, be it perforating injury, be it a hydrops for keratoconus, or be it post-infectious deep scars. Next slide. To, as I said, perform a type of graft that minimizes endothelial transplantation while allowing better refraction than full thickness small grafts. To do this, we use the microkeraton. You see in a moment why. And we know that the microkeraton has a great advantage. It creates surfaces that are compatible with 20/20 vision, although it is not as precise as we would like it to be in cutting the stroma. In other words, even if the microkeraton head says 200, maybe it cuts 250, maybe 230, maybe 190, but that is irrelevant for the purpose of what we are going to see. Next one. The idea is to combine a large anterior lamellar graft, which is responsible for the final refractive error, with a small posterior lamellar graft, which instead substitutes the deep scarred stroma, but only in the central 6 millimeter, in order to minimize endothelial removal to this small area and obtain the emulsion. Next one. Of course, we could do this in one piece instead of using two pieces, but what's the problem? For example, if you can do that with a femtosecond laser, but the femtosecond laser cuts only through clear tissue, so in a recipient cornea like the one I showed you, it is impossible. Plus, remember, to have a good fitting, to perfectly align the stem of the mushroom in the donor with the configuration you obtain in the recipient. If there is disalignment, you will have distortion in the graft and it will not be good. Instead, with the two-piece mushroom keratoplasty that you see schematized in the lower skin, we separate the two layers and we recompose them on top of each other after splitting the donor cornea into two halves. I'll show you next how this is done. Next slide. So this is the final configuration. In blue is the anterior large lamella. In red is the smaller posterior stromal and endothelial lamella. Next slide. Start the video. Just click on it. Okay, this is a child with a bad stromal scar. She had zoster. So we do a partial thickness trephination, 9 millimeter in diameter, and we go down with about half of the corneal thickness, 250 microns. Then we perform a lamellar dissection using a crescent knife or whatever dissector you like best. We use this one, that is, I think it's a Japanese one. So, yeah, it's a Japanese one. Doesn't matter. You just go towards the center, all the way around for 360 degrees. Here you see, trying to remain at the same level, in the same lamella. Then we remove that because that interferes a little bit with the full thickness trephination that I'm going to perform in the center, where I will fit the stem, the deep layer of the donor cornea. Here we go. This is 6 millimeter. Remember, the previous one was 9. And this we do full thickness. There you go. Now we remove the central lamella. There you see, with the corner scissors. There you're going. And we are open sky, but even this, it's a 6 millimeter opening. It's much better than an 8 millimeter opening. It's much more difficult, even when there is vitreous pressure, for the content of the eye to come out. And this is the donor, the deep piece of the donor lamella, and this is the anterior one. I've split them into two halves and put on top of each other after punching them to the proper size. So these two layers of the same donor are now sutured, but as you can see, we suture only the anterior one. The deep lamella fits against the anterior one like a diesel, simply. So we have been doing this since the year 2004, and we collected the results in 2016. We are still doing this. As you see, quite a large number of patients, and we have 12 months data for over 300 patients. And when I say 12 months data, it means with all sutures out. We lost about 17%, 18% to follow up, some because maybe we didn't have such a good result, we don't know. Some because they were very good and we didn't want to bother to come back again, probably. So we don't know why, but 18% is lost, which is not more than in other studies. Next one. And this is the percentage of the mushroom keratoplasty in comparison with the total number we have performed up to 2015. These are the numbers. You see we are at about, well, what is this? 50 of 400 is 1/8, is about 15%. Next one. And the loss to follow-up increases with time, of course, but as I said, it's within limits of all the studies, so it's quite physiologic to have this number of loss to follow-up. Next. Okay, here are the demographics, nothing particular, except for the thing that these are young patients because they are keratoconus and post-infectious eyes, so it's rare that they are old. Next one. Although there is one of 86. Next. And we divided the patients between low risk and high risk, according to the international classification, if there are more than 2 block hours of deep corneal neovascularization, they are considered at high risk. So about 3/4 at low risk, 1/4 at high risk. Next. Typical example of low risk, a patient with keratoconus and previous eye drops, and high risk, a patient with rosacea with completely vascularized cornea. Next one. Well, there were some comorbidities that were limiting the final result. Here they are listed. Next ones. And these are the associated procedures we have been performing. We have done open sky surgery and closed system surgery, depending on the situation of the cornea. Certainly in an eye with keratoconus, you can do phaco plus IOL in the eye with completely vascularized, like the one before. You have to do it open sky. Next one. First issue, how do they see these patients? Next picture. Well, it's amazing because as early, you see that the amount of 20/20 vision grows rapidly after 2 years, stabilizes around 4 years after surgery, to actually over 50%, more or less. It depends on the year, which one is included or not, but they're usually. And most of them, almost all of them, are 20/40 or better because they are, as I said, young patients with keratoconus or with post-infectious cough. This includes, of course, excludes those grafts that have failed, which is a small minority. You see the number. Next. Next. How is the refractive outcome? Well, at 1 year, as you can see, there may be astigmatism. This is refractive, up to 8 diopters in about 15% of cases. Next slide. At 3 years, it goes down to 13%. Most of the patients are within spectacle correction. Next one. And a small minority at 6 years has refractive astigmatism higher than 4.5. This is because the others have been corrected with surgery, and these wear contact lenses, they don't want to be touched. But most of them, we offer them to do a very simple correction of the astigmatism. I'll show you next. Next slide. Interestingly, the pattern, if we compare regular versus irregular astigmatism, you see a typical example of regular on the left and irregular with the 2 halves of the sand cloth are not on the same line. Next. We see that most of the patients have regular astigmatism, which is nice because even if it's of relatively higher degree, it can usually be corrected much better. Next. Click. This is an eye with high degree astigmatism, topographic 9 diopter, and this shows how you correct this. You don't need laser. Actually, use a prime to do laser on this. You simply open the wound of the anterior lamella for 1 or 2 clots, 2 hours of clot under while you're looking with an intraoperative keratometer. It's actually a ring of light which is projected, and it's oval. If there is astigmatism, you open up the wound in the shorter axis, and that corrects astigmatism. This is what happened to that one. It went down to 2 diopters with that simple procedure. That's the patient that had this type. So the nice thing with this is exactly this. Next slide. Now we go forward. Graft survival. And this is the most next one, sorry. We went back. Another one. Forward. Okay. And this is the most interesting issue, because you see at 5 years, survival, even in high risk, is over 90%, which is unprecedented compared to normally full thickness grafts. See, there is basically no difference. Next slide. And if we compare with PK, and with dark, we are much closer to dark than to PK. Actually, there is no difference with dark, I would say. Next one. Rejection episodes do happen, both in high and low risk, but, next one, in all cases, they went back with treatment, and you see, even if the number of cells is not that high, you must remember that there is only a small area with donor cells, only the 6 millimeter, but around it, there are 75% of the residual recipient cells that help repopulate and make the cornea clear. Next one. Interestingly, this is a case that was left alone. He didn't come back after he developed this sort of failure, And you see, we saw him at day 0. He didn't want treatment. At month 3, he was slightly clear. At month 12, it had cleared spontaneously. So this is a quite indirect demonstration that this repopulation can happen from the recipient into the donor. And we have other cases like this. Next one. Just to conclude, a few examples. This was a tennis player, a professional tennis player that had a car accident. We did a mushroom keratoplasty on him, and you see that as early as 10 months after surgery, we removed all the stitches. He had 20/20 vision with a minimal amount of cylinder, and he stayed like that for the next 10 years. Next one. It was the first one we did. You see, this is 11 years. He wears a soft contact lens, and he sees 20/20. Next one. This is a patient that had instead amoeba. The amoebic infection was healed. She sees 0.9. We wrote 20, 22.5. Again, with a tolerable cylinder, and this is 10 years after surgery. Notice the cornea was totally vascularized, and you can hardly see the vessels. Next. And this is the child of the picture. She saw 20/25, 4 years after surgery, and she never came back again because the mother was disappointed she had to wear glasses. It's difficult to explain to certain people that starting with that type of eye, she should be just happy that the child will see 0.8. An example, the next one. This is a bad herpes that we treated with mushroom once the herpes was healed, and the patient recovered 20/20 vision. 5 years after surgery, he's stable. We put him on prophylaxis against possible recurrences of herpes, but the cornea is clear, no rejection, 20/20 vision. So for all these complex situations, actually we have a rather good endothelium, but we can't do adult. We like to do this procedure because it allows long-term survival of the graft with excellent visual results. And I think Tiziano saw this with me. This offers an additional possibility to the surgeon to face cases that in the past, especially if the other eye was good, would probably be left where they are, not to experience the problems of conventional penetrating keratoplasty. Thank you.
Okay. The presentation was very, very clear. It was a very great presentation. Thank you, Professor Busin. ¿Alguien quiere hacer una pregunta? We want to know about if you have a detach in the graph. How did you manage the detach in these cases?
You just inject air. We adjustment rate is around 2%.
Perfect. Ok, professor. Ci vediamo in 2 settimane in Chicago.
America del Norte.
Okay, thank you very much and see you soon. Thank you.
Saludos a América del Sur.
Gracias.